I'm going to introduce Chris Moreland now. Chris Moreland, MD, MPH, is an associate professor of internal medicine and associate residency program director at the Dell Medical School at the University of Texas at Austin. He is an academic internist and hospitalist. As a nationally recognized medical educator, he mentors healthcare professional students across a range of professions. His research addresses health disparities impacting deaf and hard of hearing people, as well as the professional experiences of healthcare providers with disabilities. He is the current president of the Association of Medical Professionals with Hearing Loss. And with no further ado, please, Chris, take it away.
Good afternoon. Thank you, Peter, for that introduction. I'd like to thank Pete and the entire Stanford Medical Abilities Coalition team for setting up this remarkable conference and hosting all of this in the face of COVID-19. It's been an impressive response during this time. So hats off to them for that. All right, I'm just adjusting my slides here. Give me a moment. All right, thank you everybody for joining this discussion. When Pete invited me to present on this topic, I found myself becoming more of a learner along with all of you. Today, I'm going to talk about cultural humility and how that ties into disabilities within the healthcare system, in particular education. So you can see my goals for you as the audience. First, I'd like to start with the definition of what cultural humility is. Describe the gaps in education on cultural humility with regards to people with disabilities. And third, to identify resources for engaging people with disabilities in improving clinical care, education, and research. So my first poll question is this. In terms of cultural humility, when we compare that to cultural competence, what does cultural humility address? Clinical skills, framing how we approach others, or passing a written test? And I'm not able to see the responses, so I'm just going to go ahead and tell the answer. It's the second option, framing how we approach others. And I'll address this more during the presentation. My second question, potential barriers to our formal learning about cultural humility include what? Variations in educational approaches, challenges of integration across training and practice, finding content, or all of the above? And the answer is all of the above. Question number 3, which of the following is true about curricula on cultural humility? Usually set in the clinical environment, widely implemented, often incorporate patient encounters, or variable content? And the answer is the final, variable content, widely variable content. So to begin, I have no financial conflicts or disclosures. I'm not paid for this. And I want to acknowledge my own biases. Again, as I developed this presentation, I found myself in very much a learner role, learning more than I anticipated as I identified my own blind spots in the field, identifying things that I didn't know that I didn't know. So I'm learning about this topic along with you. I'd like to acknowledge my own experience and identity strongly impacts how I develop this presentation. So I do want to acknowledge that. I'm straight, white, male, deaf, and a physician. And there are several other aspects of my identity that impact this presentation as well. At the end, there's going to be a Q&A, and I welcome further questions and your feedback. So first, if you can imagine with me, what should healthcare look like? Especially in terms of people with disabilities. Just like any research project or program, we need to envision what our final outcome might be and how we are going to get there. So you can see on the screen there are two images. One, there are 4 healthcare providers standing in white coats, all wearing masks, which is appropriate given the current circumstances. They might be standing too close together, considering the 6 feet separation that we should engage in. And while this is a critical image, that's not where I want to start with this presentation. The other image, you can see what we assume to be a patient lying in a hospital bed. They're looking away, and it looks like somebody is kneeling next to them on eye level. And I assume that's a healthcare provider. You can see they have a smile and having a warm and friendly engagement with the patient. We need to remember that when we're working with patients, particularly those with disabilities, we need to take their perspectives into account. So how do we get there? Through cultural humility. Now, before I dive into this, there's a more frequent word that we're used to seeing around the country, and that's cultural competence. When we talk about cultural competency, that's more of our ability, our knowledge. What is it that we know about a variety of cultural minorities or other groups? What are their traditions? What are their cultural approaches, their belief systems, practices as a population? And how do we apply that information to each individual? Cultural humility is less focused on abilities and knowledge, but it's attitudinal. How do we, as professionals, frame our approach to each individual every day? That's cultural humility, and that's intended to be from the standpoint of learning about the other person. There were 2 people that first proposed this term in 1998. Dr. Tervalon and Murray Garcia. And they developed this definition that I'm going to let you read. The quote is there. It says, best defined not as a discrete endpoint, but as a commitment and active engagement in a lifelong process that individuals enter into on an ongoing basis with patients, communities, colleagues, and with themselves. Now, this is not a one-time change. This is not a course that we can take. This is an ongoing, lifelong process. It's more about a pathway than a final destination. It's a way for us to engage with other people and learn about them, something that we need to do on a daily basis. The concept of cultural humility allows us to adapt to and recognize individual variation within groups. As I mentioned with cultural competence, if we identify certain traditions, beliefs, or practices within a particular culture, then we can allow for space for each individual within that area. And we see differences among those individuals, and a variation will occur within that group. So for cultural humility, does it matter? What's the relevance? Most of the research that's been done on this has been outside of medical care. There were studies at one institute. The researcher looked at particular attributes or characteristics of cultural humility within their organization on a hospital level and correlated those with individual staff member perspectives of the hospital's organizational processes. So, for example, nursing communication with each other about patient issues and other similar issues. There was a statistical significant correlation between the organizations, the characteristics of cultural humility, and the staff perceptions. Much of the research that seems to be relevant about this focuses on patient communication, which again is typically focused on skills and abilities instead of how we frame our thought processes and how we approach individuals. In other words, there's not a lot of research about this in particular. Another point of relevance, people with disabilities have been recognized as marginalized from medical education, and that comes up quite a bit, or came up quite a bit on our breakout sessions before this plenary. So from a research process itself, disability has already been recognized as underserved as in the medical community within the United States. There's not enough representation of people with disabilities within the medical literature. This particular article that I'm citing here by Dr. Rios provides fantastic recommendations for improving the engagement of people with disabilities within the research. Now, I want to consider, what do we do now? How does cultural community come into play? I have 3 stories about patient encounters that I personally have experienced that I'd like to share with you. What happens if we make decisions for patients? So I'm a hospitalist, a hospital-based physician, and I was working a particular night shift, and there was a patient that was admitted overnight to my team. It was a patient that used American Sign Language. And this patient came into the hospital with a particular kind of infection. They seemed to be recovering well. But I noticed from the documentation that this patient was identified to be DNR, as a do not resuscitate. And I was struck by that. They were fairly healthy overall. So I asked the patient, and I asked them what their understanding of DNR was. And they weren't clear about the concept. So we talked, and I explored their understanding further. The overnight physician that had evaluated and admitted this patient to the hospital had had that discussion with them about code status, as it's called. And that discussion happened through note-taking, writing back and forth in English. So this deaf patient was not proficient or comfortable with written English. In fact, they didn't really recall that conversation well at all. And I should point out that no interpreter was present for that interaction. So after the discussion, the patient indicated that he did want to indeed be full code. So I followed up with the admitting physician who had said, yeah, he had thought that adequate, sufficient communication was happening with the patient. So what happens if we provide patient-centered care? I have another example. Early in my career, I was called by the emergency department to come down and evaluate a patient who I was told was deaf. They were also presented to me as having dementia and developed crushing chest pain. It was also reported that this patient was seeing monsters. So I went down to the emergency department and I met the patient and I started to sign with them. And it seems that their language use was fluent, was coherent. They were lucid. There was no evidence of dementia. And on further discussion, she was giving me details of the story, what brought her to the hospital. It seemed that all of the information that she was telling me was not reflected by the information that the emergency department had signed out to me. So I asked the emergency department to bring in an interpreter and to readdress the situation, to re-interview the patient, at which point she was discharged home. That was my attempt to provide communication services in a way that seems most relevant to the patient's needs. What happens if we provide patient-partnered care? Not just patient-centered care, but in a way that we work in tandem, we work in partnership with our patient. One patient that I had in clinic several years ago was a deaf individual and also used American Sign Language as their primary language. So I sat and talked with her about her medical needs. She indicated, based on our relationship that we had developed, that she wasn't comfortable in written English. She wasn't comfortable with reading English. So she had some concerns with being able to read the prescription on the prescription bottle as it was written. So in discussion with her, we decided that we would use the electronic medical record, and she would sit and read over my shoulder. And what we did is we talked about the best way to write something in English that she would clearly understand. So I would give her the information, she would explain it to me how she needed it to be written, and I would enter that in the electronic medical record. And that's a powerful example of partnering with a patient. That came from my understanding of their background and their needs because of our shared experiences. So how do we as professionals in general learn about disabilities and cultural humility? And again, the content is widely variable. Health professional school curricula, if they present that in their curriculum, it's very scant. Dental and medical school students report that they feel very unprepared to work with patients with disabilities. They respond to that at 75% or more. The curricula that are present in the literature predominantly talk about providing education in preclinical settings. In other words, during didactic settings, small group discussions, classroom-based environments. One of the few examples of graduate medical education or residency curriculum is one program whose content addresses quite in depth the experiences of several underrepresented groups, including religious and LGBTQ groups. But there's no specific mention of individuals with disabilities. I do have one example of a nice program that addresses all of this throughout their curriculum. This particular study, the program provided education in a variety of contents and contexts with approaches and methodologies. So as you can see, from year 1 through year 4, and this is of medical school, they use didactics, patient involvement, community engagement, research, especially during 3rd and 4th years. So that was limited only for the 1st and 2nd years. So how else do we learn? From our patient perspective, this means that we need to be able to engage with and interact with our patients successfully and effectively. So if we consider the environment with where we're learning, within school and out in practice, the environments are frequently inaccessible for a variety of different reasons and in a variety of different ways. If we're not able to connect with our patients, we're not learning effectively from them. and we're not practicing cultural humility. So how do our patients engage with us? One issue about people with disabilities, as we've discussed in the breakout groups recently, disability is something that people incorporate within their own identity in a variety of ways. So, for example, I've never really identified as a person with a disability, but I do identify as deaf. So that recognizes part of how I've gone through my life. And that also impacts how other people might identify me. A number of people today have talked also about elements of intersectionality and how different parts of an identity, race, ethnicity, religion, and so forth, how those have an impact or interact with our disability identities. We make too many assumptions about our patients and how they identify and how they connect with these issues. How do our patients access the location where we practice? Lisa Iazzoni has a wonderful book, When Walking Fails. It was published some time ago, and it investigates how people with disabilities, how people's disabilities impact their care. There are other forms of access. Can you call into the healthcare system? Are you able to navigate a phone tree? What do the forms and the signs in the hospital or clinic look like? And do we create a climate of safety where patients and community members feel free to let us know how best to improve that to meet their needs? Without these elements, we can't practice cultural humility. What about learning from our colleagues, from each other, from the other professionals with whom we work? I propose that this is one sustainable and powerful way that we can practice cultural humility in our practice. You've already seen discussion about several national organizations with deaf and hard of hearing people, healthcare professionals, as well as other healthcare professionals with other disabilities. I list two here, but this is just two. There are a number of others. There's the Association of Medical Professionals with Hearing Losses and the Society of Healthcare Professionals with Disabilities. I've received feedback from multiple students and colleagues over the years. Because of our opportunities to work together, they've felt more comfortable communicating effectively with patients who are deaf and hard of hearing or even who have other disabilities. I have a colleague who is a deaf physician, and they said that during their training and during their programming, they were once asked during their residency by their program director, they had asked their program director to not cover his mouth while he was speaking. So the resident asked the program director to stop doing that. Later, the program director came back to that person and said, I realize that makes a huge impact on how I communicate with other people as well. That's another example of how an experience from a colleague can shape and carry over into our practices with other individuals. At the organizational level, there are multiple organizations that are out there that I'm only going to identify these three in particular and talk about these and the ways that I've seen them practice cultural humility. The Society of Hospital Medicine, SHM, they use the term specifically in developing their 5 R's that are listed there on the screen: reflection, respect, regard, relevance, And those 4 lead to resiliency. The American Medical Association has developed graduate medical education competency program. And that's one example of a national curriculum that's available for programs in general. This is not specific to address cultural humility, but it's one step on that trajectory. The American Psychological Association has a multicultural guideline connected to cultural humility elements. Those are just a few examples. There are multiple that are out there. And I'd like to emphasize some research that's ongoing in terms of healthcare professionals with disabilities. If we're going to be learning from each other as professionals, then we have to engage the people with disabilities to work alongside us as professionals. Some examples are listed on the screen. Dr. Lisa Meeks has already presented earlier today about quite a bit of research. I'll try not to repeat the information that she's already provided. There's one study that we began last year. We surveyed deaf and hard of hearing healthcare providers and medical students in collaboration with UC Davis and Dr. Meeks. UC Davis in particular has a Center for a Diverse Healthcare Workforce. And I would like to acknowledge and thank UC Davis and HRSA for engaging us with this critical work. The work has yet to be published, but there is some suggestion of effective communication for deaf and hard of hearing professionals in terms of how that supports their entrance into the workforce. We're doing qualitative analyses to better understand those experiences. The AAMC, the Association of American Medical Colleges, has begun exploring the experiences of people with disabilities. It started a few years ago. One of the medical student questionnaires, the graduate questionnaire, now includes disability items, which allows us to track people with disabilities longitudinally and see the impact that those disabilities have on their work. The AAMC also has begun to include disability items on their survey at the national level for physicians. Creating this environment for people with disabilities to be engaged with the healthcare workforce requires that we provide a climate of safety for people with disabilities. We need to be able to feel free to respond to and engage in different ways with our institutions, our colleagues, and our patients. Our goal should be to work towards improving the care for people with disabilities. But we also need to support their time and energy as we include them in this process on multiple levels. I'll come back to my patients that I spoke of earlier. I mentioned one woman who was noted to have dementia and seeing monsters and had crushing chest pain. She was brought to the emergency department. As I talked to her, I realized that she did not have dementia. That was clear from the first moment that we began to speak. And as I asked her more about her story and her history, she contacted law enforcement with concerns about her neighbor. There was no interpreter available at that time. And through some severe miscommunications, she was brought into the emergency department because her sign for fear was misunderstood by the provider to mean crushing chest pain. All of these miscommunications that began at her apartment when law enforcement first arrived, all the way through her arriving to the ER, led to extended testing and an extended hospital stay, medications, imaging, all all of which never needed to happen and could have been avoided had an interpreter been provided. Because I happened to be the hospitalist of the day, I was the one that came down to interview her, and I was able to engage with her directly. And we were able to send her directly back home from the emergency department without being admitted. I followed up with my emergency room colleagues about the importance of having interpreters available when they're dealing with deaf patients. With all of this information, what can we do to move forward? There are a number of things that I'd like to highlight, but 3 in particular. 1, we must incorporate cultural humility across the health science education curriculum, from the preclinical environment up to and including continuing education when we're out in practice. We must look at the clinical environment and make sure that the information that we're including is not just in didactic sessions, but is engaged in the curricula on a daily basis. I think as a country, our health professional education system has begun to shift markedly to self-reflection, how we look at ourselves, how we understand our biases, and how we understand those to impact our practice, but that work needs to continue. Second, we need to include people with disabilities in education, research, and clinical care. Not only as participants for representation, but also as professionals. We need to engage people as professionals, and we need to allow them to have a place at the table to help us make appropriate decisions in terms of care, policies from the individual level all the way up to the institutional level. Third, we must develop proactive policies to support accessible environments and accommodations for both, for participants and professionals. As we see, given the current circumstances with the COVID pandemic, this is of particular importance, as crisis can worsen existing disparities. And I don't want to end on a point where we're talking about things getting worse. We have made so much progress over the years. We've done so well. We've worked hard to make sure that we have improved the care and advocacy for people with disabilities and engage them within this work that we've been doing and you've been doing. This is my contact information if you'd like to follow up with me afterwards. And now I'm going to open up the floor for questions. Thank you.
I'm going to introduce Dr. Elena Engelman, my colleague, who will be moderating our Q&A session this afternoon. If you have any questions or comments, please place those in the chat box.
Yes, it's so wonderful to be here, and thank you so much for such an outstanding presentation on cultural humility and patient care. There seems to be a bit of a time lag between the video, and I'm not sure why that is, but I'll go ahead with some of the questions. Now, given the Black Lives Matter, the movement and the crisis that's been happening, how can we best provide patient and humble care with those people who have intersectionality identities with their disability or disabilities? We just recently lost a great disability activist, a justice activist, that's Milburn, who self-identified as queer, disabled woman of color. She was a community organizer. She had support of homeless people who were affected by the virus and disabled people whose lives were seriously at risk due to the power outages. How can we amplify their voices, the voices of these disabled people whose lives are intersectional, and the healthcare profession, with the goal of providing culturally humble care?
Thank you so much for that question. That's a really timely question, so relevant to our current circumstances. I agree. I think that first we need to create space for those discussions to happen. Often, and typically during crisis like the one we're in now, we find ourselves just focused and following our traditional patterns to get through these crises. We create explicit space for discussion and actively engage people from a variety of different backgrounds in the discussions, and we need to listen. Too often we're in a hurry to try and develop policy, to look at only brief periods of
Absolutely
engagement with
right.
communities in order to develop those policies. These things take time for people to think, for people to listen, to exist in conversation. And I think that it has to happen repeatedly over a period of time. And that requires support from our leadership, our institutional leadership, to make that space available.
Yeah, they have to recognize what they don't know and be open to seeking those answers. Which leads me to another question. There's been recent research that's been, saying that implicit bias training is not necessarily going to change the autist attitudes. So if that is the case, what do you recommend that we do in this field so that we can address the cultural humility?
As a medical educator, my first response to this would be that those types of discussions have to be integrated into the daily experience of students. We shouldn't be relying on one or two or periodic training to develop these skills. This sort of humility and attitude change takes a daily and concentrated effort. We need to have these discussions with patients from each background regularly. As medical educators, we have to lead these discussions with our students. One example would be that oftentimes I find it tempting to move quickly through my content. If we're going to see a patient with a specific kind of infection, for example, pneumonia, we want to get in there, assess, treat, but we're not thinking about their backgrounds or where they're coming from. If we build that into each and every discussion that we're having with our students every day, I think that's critically important to shifting the way that we look at and teach cultural humility in the institution.
I am so glad you brought that up, which leads us to the audience questions. We've had comments that they've heard that clients or patient-centered care. Well, they've heard of client-centered, but not patient-partnered. Can you share if this concept is new and how is it being used or applied in the field currently?
Thank you so much for bringing that up. I decided to use that particular terminology, which is not widely found in the literature at this point. I would like to see it used more often, as a matter of fact. The way that we've seen this term, patient-partnered care, used has been explicitly the way that we engage with our patients and work together with them to make decisions. The decision-making process is shared. The term patient-centered care is also important, but it still implies decision-making by the healthcare provider solely or primarily with input for the patient, from the patient.
Exactly right. It's not a two-way street. It just seems to be going one way.
It's just a bit of a different lens, a different framing for the decision-making.
Well, in terms of the big picture, and also a practical issue, we have a question from the audience. The person said, well, a resident hold on just a moment. A resident who lip reads because of a hearing loss seems to have more issues because of the COVID crisis, because everyone's wearing a face mask. Would you recommend a face shield rather than a mask? And how do we encourage institutions who require a mask to allow them to do so?
Yes. In the organization that I mentioned earlier, Association of Medical Professionals with Hearing Loss, AMPL, we have repeated requests about this exact issue. A number of our members recognize the challenges that exist, even people who have been practicing for a number of years. We're finding new challenges now that everyone is masked. We can't use those lip reading skills, we can't look at people's expressions, and there are a few ways to address this issue. One way would be the face shield, as you mentioned. That is definitely one option. That concept is relatively new for me. We're seeing that more and more often, but that is a nice solution. Secondly, there are a few companies producing surgical masks with clear windows so that you can see the mouth. That does seem to help. And I would definitely encourage institutions and programs where deaf and hard of hearing patients and residents practice or go for their care, for those staff to have a supply of masks. There are benefits not only for people who are deaf and hard of hearing, but also benefits to a variety of different patients. For example, children who might feel more comfortable seeing their providers' faces, or people who are at an older age who might have hearing loss that they need to use those visual cues to communicate with. That's a solution. Again, there's not a one-size-fits-all approach. And I definitely encourage institutions and educators, administrators, to all have a frank conversation about the variety of perspectives that exist by these practitioners and the patients in those institutions.
I'm glad you said that, because you're right. There is no one-size-fits-all approach. Another question is, how do we encourage the institutions to do more than just being in compliant with the ADA and meeting minimum basic requirements? This came from the audience, by the way.
That's one of the biggest questions. Absolutely. That issue requires leadership.
Leadership,
You have to have buy-in from leadership, and at every level, actually, especially at the institutional level, and at the government level as well. As other people have mentioned today, the principles and intent of the ADA, are often not instituted in the way that the policy is enacted. They have a lot of work that we have to do on that.
Yes, and suppose a student wants to bring this up to their program director. How can we work with them so they can continue implementing disability studies? I mean, as a student, I'm wondering, maybe I wouldn't even feel comfortable. Do you have suggestions or an approach?
I strongly encourage people with disabilities, students, practicing professionals, anyone in between, to propose ideas based on your experiences and contribute to the education of coworkers and staff in your institution. Quite some time ago, several years ago, one interpreter and I that I was working with, we proposed developing what we called an OSCE, O-S-C-E. This is a medical education experience for med students. And we proposed having patient actors, standardized patients who were deaf. And then we taught students in a module about working with interpreters. We were able to watch them work directly with interpreters and the deaf actors. It was a phenomenal experience. The students loved it. They didn't realize what they didn't know about these types of encounters. So we helped them to identify some of their blind spots, some of their areas of opportunity, and develop skills to address those. Yes.
So maybe when a student brings this up with a program director, they can say how much they can benefit, and not just them, but all students would benefit. It's a very special issue that needs a specific group of people, and it does impact everyone in the medical practice.
Definitely, definitely.
Another question from the audience. Patient partnered care, is that different from shared decision making? Are they the same or are they different?
see them as very closely related. I don't consider myself an expert on the nuances between these two terms, and I don't think the terms are consistently defined as of yet. I think that patient-partnered care drives effective shared decision-making.
Well, there's another interesting question that just appeared, and this has to do with liability. Now, with the face shield question, what if it doesn't provide enough protection for the patient and maybe only some degree of eye protection? Do they need to get consent before they can wear it?
If you're asking about the use of a face shield separately from the masks with the windows, I don't mean to advocate for face shields alone. And I'm not familiar enough with the evidence there, but my understanding is that it's becoming feasible as an additional layer of protection or an additional option, but it still provides the ability for patients to look at the whole face. You know, I think I'm answering your question. I'm not sure if that was exactly it.
Yes, you are. Now, here today in the audience, we have an awful lot of people who identify as having a disability, whether they're a med student or a physician. Now, I'm wondering, can someone bring their own interpreter if the institution is not paying for one? Or does one have to use a quote unquote approved vendor?
People in the audience who are professional students with disabilities, I want to make sure I understand the question clearly. If the question is about bringing your own interpreter, I'm assuming that you mean you're bring the interpreter into the educational experiences, or?
It seems to be related to the educational experience, but it's possible that they could mean residency. It isn't clearly stated.
Well, in compliance with the ADA, as we mentioned, institutional programs in schools should be providing those accommodations for your education. Students and residents especially should not be providing their own interpreters and other accommodations.
Well, that makes me wonder how to respond to other practitioners who don't want to pull down their mask for those visual cues. They would use other tools. What would you do in that situation? That's a challenge.
Definitely a challenge, and we don't have an easy answer at this point. I think all of us as practicing professionals are coming up with different ways to communicate effectively during this time. I do know one practitioner who tends to communicate very well in several different methods, and now they've found that writing notes back together with colleagues who don't want to pull down their masks is one effective communication strategy. In other environments, they might distance several feet from colleagues who then pull down their masks to have a discussion. A variety of different things. So we're finding ways that are safe and protect both us, our patients, and our coworkers, and optimizing communication in any ways that we can. And that's, of course, going to be different for everyone.
Well, that's actually a very great beginning to a discussion about this in terms of how to communicate with your peers too. Suppose there's a code blue where everyone must wear masks. Then what do you do?
Oh,
Are there
definitely.
specific tools that you might use?
That's one example of communication in crisis. If a patient is crashing, how do we communicate during that emergency situation?
Right.
That's one example where developing policies about effective communication ahead of time are definitely critical to the success
right.
of the encounter.
Time is of the essence. We need to think about that at the beginning and don't come to that conclusion as an
Yes.
afterthought.
And that's not only true for people who are deaf and hard of hearing or who have other specific legal disabilities. That's true from an institutional perspective as well. The way we as professionals communicate with each other using specific kind of technology, as individuals, we should be thinking about those specifics ahead of time as well, with input from colleagues, managers, educators, etc.
Well, thank you, Chris. I know it's coming to the time where we need to wrap up pretty soon. So I have the last question from the moderator, Purna. Based on your experience, is there a way that the patient can Centered care for all patients. Can there be ways to make improvements in cultural responses for patients with disabilities, especially when you're thinking in terms of humble care? And, I know I kind of branched that off into two separate questions, but I've been thinking that there are people in the audience who are deaf or hard of hearing as med students and residents, so I'm sure they want to know all this.
I see a few different responses, different approaches that were related to several answers we discussed in this previous session. I think establishing proactive policies, having conversations early in the process with a variety of stakeholders involved is crucial. Again, creating space for these discussions with our patients and our community, our colleagues, to have those really hard discussions, to innovate, to address challenges, and maintaining those spaces during the crisis.
Right. I think the medical students and residents, they wonder how can they get their foot in the door in terms of being medical advocates for students and patients with disabilities. We've got the COVID crisis. There's so much to think about now.
Yeah, the crisis has created a host of opportunities for innovation to step in. We've seen many medical students around the country, because they have not been able to participate in patient care. They found other ways to contribute, calling patients at home, following up with contact
Right, we
information
have
after
video
discharge,
telemed,
doing video telehealth visits, doing screening. So this is a very powerful time for innovation and opportunity.
Exactly. And in the breakout session, you should have seen it. There are some people who felt inspired. They want to continue the conversation and maybe contact other parties who can join us afterwards so that we can continue this. And it won't be just a one-day event at a conference, but the conversation can continue. Thank you so much for such a wonderful presentation.
Thanks for your time.
Sure.